Good evening. I apologize for the delay. We finally overcame the technical difficulties and we are here. So I'm glad everybody was able to join us tonight. We have a open discussion with Mr. Don Self, who is a legend in the coding webcast community. We have Julie Miller, who is an expert in revenue cycle as a revenue cycle analyst. And we also have Jennifer Kropp, who's a current production coder for Capital Health. So what I'm going to talk about today, and we're all going to talk about collectively, is primary care coding. This traditionally is like the overseer and the gatekeeper for medical care. Usually your primary care provider has a kind of general knowledge of medicine, and they can treat multiple conditions, and they refer to more specific care. So the kinds of treatments that are included in these kind of office visits by these providers will be routine examinations, will be complaint related examinations, and any minor services. So primary care services cover a wide range of disease and treatments. So as a coder, you would have to be able to have a broad sense of coding for these providers. So I want to ask our main guest, Don Self. So in regards to primary care, I have seen different titles such as PCP, internal medicine specialist, and family practitioner. Is there any difference between these kinds of roles in the medical setting?
Yes, there are. In the medical setting, there is because usually internal medicine providers are getting more into clinical lab and more as a diagnostician, where a family physician is typically taking care of everybody from youth till, well, from cradle to grave, basically.
Okay. And with these different types of, like, I want to say medical specialties, primary care, internal medicine, family practitioners. From my understanding, there's a whole system CMS created called the of the of the of the provider taxonomy.
Sorry, I kind of lost a few of your words there. You kind of cut out for me, John. I'm sorry. Can you
Sorry.
ask that question again?
Medicare has this long list of medical taxonomies, and how do these kind of different specialties kind of relate to primary care, or how services are kind of categorized, or how practitioners are categorized when it comes to primary care treatments?
Now, is that for me or for Jennifer or Julie?
That's for you.
Oh, okay.
I think as the expert in kind of the I want to say the heavy complicated and the kind of foundational things from Medicare, the internal cogworks of the insurance companies, I think you're the best suited for that.
I don't know about that. And let me explain why. Because I never really get into the taxonomies, and I'll tell you why. Taxonomy is dealing more with the HCC type of reporting than it does the actual billing side, where I look more at the specialty codes like 08 for family practice, 11 internal, 38 for geriatrician, etc. And that's dealing more with the reimbursement side. And as a reimbursement consultant, I'm more of a reimbursement consultant than a coder. I would wager these lovely ladies right here with us could code circles around me. I'm the guy who takes a look at the practice and says, "Hey, doc, why are you not doing this right here in your practice?" Or why are you not billing out for removal of impacted serum? And when you're actually doing that, and there's two different codes for that. That's the kind of approach I take. So I don't want to mislead everybody and think that I really get into the HCC and the metrics of the basically the HCC type coding. Does that make sense?
Yeah. Oh, yes.
Mm-hmm.
Now,
All
Julie, do you get into taxonomy code very much?
I get into taxonomy codes a lot because of the fact that the way that the provider is credentialed and how it comes across in terms of the payers. Yes, I always have to sit there and be very, very aware of that because it does affect actually the reimbursement side as well, depending upon the contracting.
Okay.
I
So,
agree with that.
I'm here to learn something too then. I'm not one of those that think I know it all. Trust me, there isn't a day that goes by that I don't learn something new.
But yeah, it comes into play with contracting quite a bit. So it also depends upon what type of a clinic you're dealing with. We here out in the Southwest, we actually went from a fee-for-service clinic with our family medicine to a rural health clinic. And I actually have a background in federally qualified health clinics as well.
So when did you switch them over from being fee-for-service to RHC, and what do you think that's done to their income when you've done so? I'm just curious.
What it ended up doing is, because of the reimbursement side of it, the air payments actually ended up making a difference for us overall, because the fee for service was actually slightly lower and cutting into the providers' RVU. Well, not necessarily the RVUs, but in terms of reimbursement, it was actually cutting into it, based on the fact that the way that we bill for RHC, we bill out the labs along with certain procedure codes as well that can actually make up another air payment besides the original one with the E&M coding.
So that's interesting.
Okay.
So we have two different ways of being reimbursed for primary care. You can go where you're only billing for fee for service, where you're billing for the labor of the provider, or if you work for a company like an RC, which is a rural health center, where you collect everything. Labor, all the other ancillary services, nursing care, any kind of lab panels. So you can bill for that. So that's interesting. And so that may also happen in an office setting too. So if you, I believe there's a thing called a CLIA waiver. So if you can perform certain services. Now, this is more a question for Jen, because I know she sees a lot of CLIA waive services. So can you explain and how it impacts like any kind of in-office lab draws?
The CLIA waiver, it's tests that are, there's a waiver put on them. I don't know the proper definition of it. I know that our scrubbing system flags the claims if they don't have a QW modifier on them, which indicates it's a CLIA waive test. I'm trying, my mind's a blank right now for the CLIA waiver.
All right. Well, I think CLIA waivers are certain services that are kind of so routine and so simple to do that they don't have to have any kind of a complex, complex analysis. Something that can be done simply, and they kind of bypass the requirement for a kind of an open laboratory system, which
certified lab technician. The testing that they have to go through in a regular lab that's not CLIA waived.
Yeah, so there's a lot. There's a lot with it. So
in regards, I think a lot of doctors do testing like that because they don't know that they can be doing it in their office. They think that it has to go out to Quest, LabCorp, et cetera. So I think educating the providers that there's more clinical lab application in the office I think it's a good idea.
Yeah, and there's more and more services that are becoming so routine they can be done more commonly in the office. So we're seeing more and more of that. So it's not just evaluation; they can get results that day. There's a lot of urinalysis that all you do is like you do some kind of reagent. I
have a definition here for CLIA waiver. It's simple laboratory examinations and procedures that have an insignificant risk of an erroneous result. That's what a CLIA waiver
is. Such as drug panels are really good for that. Simple drug panels are really good for that. What else do we do? I'm trying to think of all the stuff that I was coding earlier, and I can't think of it all offhand.
It states the FDA determines which tests meet these criteria when it reviews manufacturers' applications for test system waiver.
All right. So we've gone over a lot of different things that might be in the high-end coding, but let's talk to Jennifer now. So in regard to what you do daily, what is a good portion of your day spent doing? Like, what do you see commonly? Can you just walk us through your day as what is your day like? What do you do?
What do I do? Well, when I'm auditing, I audit charts. I review charts for what the doctor billed for to see if they meet the criteria and the guidelines that CMS puts out for the particular code. that they're billing for.
What are some of the common things you see when you do primary care? Is it a lot of office visits? Are there some visits where they do other things? Like, what would any coder that wants to do primary care, what should they expect to see when they're actually in that
You will
record?
see a lot of vaccinations. You will see a lot of physicals. You will see a lot of Medicare patients. That Medicare has a set of guidelines and codes unique to Medicare only. The things I see over and over again, time-based codes. You have to look for time in your documentation. Injections, NCD numbers, you have to reconcile them to make sure they're the correct NDC number.
Now, what's an NDC number? So for the people listening, what does that
The national drug code for all drugs listed.
And you use that in relation to what? Like if they prescribe
When they bill, they're going to bill for a vaccine or a drug. We reckon each code that they're billing for has its own. Each vaccine has its own code attached to it, and that's what they bill for. And they bill for administration of a vaccine or a therapeutic injection for an injection. Say a steroid injection. You want to make sure that your codes reconcile correctly with the proper NDC number. You want to make sure your dosage is correct. There's some codes, some drug codes that are billed in certain increments of units. You have to check all of those things to make sure that they're all correct. There's always some quirky things that go on, but it's repetition. And you learn certain things if you do them enough by the repetition of it.
Is there anything you want to add, Don?
One of the things that I look at, and I don't get into the NDC numbers like she does, but I want to make sure that they're charging for the administration whenever they're giving it.
Absolutely. There's a lot of providers that forget to put the administration on.
In fact,
We get reimbursed at a G code for basically the pneumonia and flu for RHC, and then everything else for commercials is based off of a 90672, I believe. Don't hold me on that one. Yeah, that one. That's close.
I'm hearing a lot of static on somebody's line. I'm not sure who had static. Is it me or?
I don't know.
Sorry.
Does that sound clear?
No, John, you sound staticky to me.
Okay,
Well,
let's
go back to the question about administration. So you were saying if the provider doesn't add the NDC code, or they don't add the administration, what happens?
Our system has a scrubber in it, and it throws an edit on the claim, which means someone has to troubleshoot that particular claim issue, which is the edit. I call them edits. Somebody may call them tasks. Each system has its own way of describing it. Ours is called edits, where I work, and we work those edits. Coders fix them, and that's a good portion of my day as well. Going through edits and correcting the edits.
Gotcha. So you typically see its edits with other kinds of services, or mainly with the injections?
Oh, it varies. It could be an incorrect diagnosis code. There's edits for everything.
Okay. So in regards to incorrect diagnosis codes, like what are some examples that you would see that could be coded incorrectly that you'd have to fix? Like what commonly is like the biggest issue with that? Is there things that...
A common one is I see BMI. Adult BMI on a child. Pediatric BMI is different than
Pediatric
adult
BMI is different than adult BMI.
Diagnosis code.
Diagnosis code.
Male and
Female
specific
diagnosis
diagnosis code.
code.
That always
says
says if you have a male
patient
with a
with
female
a female
diagnosis
diagnosis
code.
code.
Age, anything with age. It varies. It could be
It varies. It could be
a lot of different things.
a lot of different things.
All right. So if there's any issue with the diagnosis not being matching, so the code will find out what the report can go out. And when I say go out to the payer or go out to the patient.
I didn't quite hear all that, John. I'm sorry.
I didn't quite hear all that, John. I'm sorry.
We're having some kind of replay. For those in the audience, if you are working in primary care and with from diagnosis, where there's a patient of right age, or maybe they're not right. They're not of the right gender. So they have the code not only male, so might cause problems with playing for the insurance company to understand it can't be. So these kind of issues were the ones that you would see for a daily fix as a coder. Is that what you're saying?
Yeah.
Yeah.
If I can toss something in here, if I may.
Yeah.
Because a moment ago we were talking about how many doctors, they don't always bill out for the administration. Give you an example. As we were talking, I pulled up some Medicare CMS data, and there's 86,700 family physicians in the country that saw Medicare patients in 2021. Only 13,790 of them billed out for a 96372.
Wow.
And only 34,000 billed out for G0008.
That's interesting.
Yeah.
Very.
I love pulling up these stats and pulling up these numbers.
So that's lost money.
Yes, that's lost money. The average, if I may toss out something, the average primary care provider in the country, just on Medicare patients alone, are missing somewhere between 70 and 400,000 on average.
Wow.
A year. And they have no idea. It's like most of them have no idea that Medicare patients, when you're in family practice, Medicare patients are 4 times more profitable than any other patient that they could see if they're doing what Medicare wants them to do. And these nodding heads tells you that these ladies know exactly what I'm talking about.
So what kind of the provider if they want to get injection? Should they realize that or do they not get the injection? Is it something that they wrote their MAs to do, and maybe that's why it slipped through the cracks?
Well, it's not just the injections. I mean, that's a small part of it right there. At maybe it's somewhere between $19 to $37 for reimbursement for the active administration. They're not doing things that Medicare wants them to. Only 12% of Medicare patients received an annual wellness visit last year. I'm on Medicare. I'm 67 years old, and only 12% of Medicare patients got an annual wellness visit. Only 9% got advanced care planning, and only 7% got chronic care management. Am I right, ladies?
Yep.
And they have no idea what they're missing, and these docs are whining and crying because they don't make enough money, yet they have no idea what they're missing out there.
So let me back up. What is an annual visit? Is that something that is different from normal visit?
Yes, and it's not what the doctors think it is, or their office managers or billers. They think it's an annual physical, and it has nothing to do with a physical. It's a record-keeping visit only that can be 100% performed by a nurse. In fact, a nurse can do one for a doctor on a regular phone call, not even an audio video. We're talking a phone call with a patient that goes to the wall, you know?
Yep.
Yet they have no idea. And if they're doing the AWVs the right way, they're going to generate between 400 to 600 a year on each patient because they're doing the services that Medicare wants instead of that $127. Am I right, ladies?
Yes, sir. Yes, sir. You are.
I know.
The Medicare annual wellness does not require an exam,
Right.
but most patients want that exam.
But they also, the doctors don't know that since 2012, you can do an annual wellness visit at the same visit as a sick visit.
Yes, you can.
And these are just a few of the little tips right here that folks like these lovely ladies here know about this stuff, but most office managers do not, and most primary care doctors don't. I was just spoke at a physician conference in Oklahoma a while back, and I had about 150 osteopathic doctors sitting there, and they looked dumbfounded whenever I was sharing these things.
So when you have an annual wellness, you have a problem with it. How do you determine which? How can you split apart to get annual wellness as the exam and say a complaint visit? We should look for.
You can actually go both.
Go ahead. Julie, what did you say?
In all honesty, you can actually bill both of them.
You can. You just have to make sure your documentation clearly delineates what part of the visit was a sick visit, and then what were you doing as far as the annual wellness visit, and did you also do either a depression screening or an alcohol misuse screening? Did you go over the end-of-life decisions with the patient, asking them, like, in the event we find you're not breathing, do you want us to hook up the battery cables to the Toyota and try to jumpstart you? And if we can get you jump started, do you want to be put in a breathing machine? And if we can't get you jump started, do you want your family to go out and spend about 10 grand on a box, or would you rather have your body cremated and your ashes put in a Maxwell House coffee can in your backyard? Just go over the advanced care planning. That's easy money too for the practices.
Yes, it is. Time-based code, though.
Yes, ma'am.
Yes, it sounds like a lot of these are kind of like audio-based conversation as opposed to like actual on. You see more of that, more like education, counseling, or are there a lot of hands-on treatment in the office too?
Are you asking what the doctors do or what we do as billers, coders, and consultants?
When you're reading a note, more of like conversation treatment or counseling, or are there a lot of hands-on? Wow, like that you would think you'd be in like an ER or an urgent care for that.
I wouldn't really recommend these kind of services we're talking about in an ER. Urgent care clinics do it because the primary care doctors are not doing it. It's like I've got cardiologists doing chronic care management on patients and annual wellness visits because they know the primary care providers aren't doing it out of ignorance, in my opinion.
So beside anyone said this injection and complaint evaluations. One thing that you can see in the office setting that any primary.
I didn't hear all
I think
of
you're
that.
asking what else can they do. Your signal cut out. I'm thinking you're asking what else can they do other than what we mentioned that's going to benefit the patient. I'll give you a good example. I'm going to ask Julie a question here. Julie, since you have an RHC, and I noticed you said you're billing out for obviously the correct things so that you can bill them in addition to your AL, the services to Part B for the clinical lab and the diagnostic testing on the technical side and things like that. Well, have y'all been doing chronic care management on your patients in that RHC?
Yes, we have it for cardiology. We do it for family medicine. And then we're also going to back up with our center.
Okay, and you know that as of January 1st, you can start doing it for remote patient monitoring also.
We've already done that too.
Okay, good. I got an email from CMS today that I am going to be speaking at the Texas Association of Rural Health Clinics about, because the way it is going to be a whole lot more advantageous than most practices realize. CMS said you're able to bill up to 4 RPM codes or GO511 4 times just for RPM alone, one for each of the following: 99453, 5457, and the 99091. Which I have to tell you folks, I own an RPM company, and that makes me real happy.
Yep, it makes money too.
It's going to make the clinics a whole lot more money on that than they would be making if they were fee for service. It's going to make RHCs a lot more because the reimbursement ratio is so much higher.
Exactly.
So that's kind of what we're talking about. And primary care clinics, they need to be doing things like ABIs on their diabetic hypertensives or their smokers. And yet most of them don't realize that if you're doing 2 a month, you're making a profit, even if you go out and buy brand new equipment. They don't know what they're missing out there.
They don't.
So, yeah.
Where can somebody that did primary care get like a list they can see what they can do? Or what are some resources where they can find out what they can do with primary care, so they can know how to code these when they have to get hired multiple.
I usually check the Association of Family Medicine. CMS is a good one.
I like going to CMS. I don't like going to AAFP or the ACOFP because it seems like they are the ones that's telling the practices pretty much what they can't do instead of what they can do. I've had a real problem with that, and I've spoken at both national associations, and I've gotten irritated with them because they're following the AMA's guideline of, well, you can't do that. We'll leave that to the specialist. Well, I'm a believer that the primary care doctors are the gatekeepers. They're the ones that need to be doing these kind of things. Would you agree, Julie?
Yes. It depends upon for us at least. We do have the specialties that are there. So depending upon what happens, then we advance them on.
Okay. But at least you're doing it like you probably do an ABI to determine whether or not they're having problems in their feet due to some kind of circulatory problem.
Yes.
Rather than muscular problems.
Yes.
So then you'd know whether or not to send them off to a vascular or a cardiologist or ortho, right?
Correct.
You see where I'm going with this, John? If the primary care providers are doing what they should be doing a lot more than they are. How many times have I seen my wife go to a new primary care provider and they don't even check her feet, and she's been a diabetic for 20-something years? It's just, that to me is just criminal.
Yeah.
As y'all start to figure out, Don is very passionate about some of these things. And there's so much misinformation out there. I mean, it's like providers out there. I just did a webinar the other day, and they have no idea. Primary care providers have no idea that they can be out of network with a Medicare Part C plan, and the plan still has to pay them the same amount that Part B would be paid. But yet they believe so much misinformation. So I'm sorry, I get upset about these misinformation out there.
So in regard to that is your like your local payers, your local Medicare Max. Your local Medicare Max is your Part B. Whereas Medicare, that's Part C, right?
Yeah, Medicare Advantage plans are Part C, and CMS has it on their website that they want to get out of processing Medicare claims by 2030 and have every Medicare patient in the country switched over to a Medicare Part C Advantage, or I call a Medicare Part C Disadvantage plan, which really bugs the heck out of me because I'm going to go fighting tooth and toenails before I give up my Part B.
I would.
Yeah, I wouldn't.
It just
It just seems
I've seen that usually with part B, there's a lot more kind of guidelines published, whereas with your Advantage plan, you have to hunt down
I've got a problem with the Part C plan, Medicare Advantage plans lying to the patients, lying to the doctors. I mean, I like Andy Griffith and Kelsey Grammer and Bill Shatner and Joe Namath and all those people, but they're lying to the Medicare patients on TV every year, making them think, well, yeah, the Part C plan is great. You get all this stuff for free, but they don't tell them what their copays are going to be. And a patient, I'm sure if you ladies have ever seen anybody with a cancer or a heart attack go through their copays with a Medicare Part C plan, some of those people have tens of thousands of dollars. But you don't if you
It's
would
due to the
have Part B.
deductible.
Pardon me?
It's due to the deductible in
Which
terms
I
of
would
in terms of this plan.
I'd rather pay my $226 a year for my deductible and not owe 10,000 like you get with a Part C. And they also don't tell them that whenever you decide to go back to Medicare Part B, you won't get a Medicare Part G plan. Medigap plans don't have to write you them because you've got a diagnosis. And they don't tell the patients that. And they don't tell the doctors that you don't have to have a pre-authorization on everything. They make them believe you do. There's just all kinds of lies out there. So I got a real problem with Part C. In fact, I had a meeting last week with a U.S. congressman, and I'm preparing a PowerPoint presentation to go to D.C. to present to different congressmen up there in both the House and the Senate, both letting them know that America's getting screwed over by these Part C plans. I know I'm waving a banner here, folks.
Oh, it's clear. This is good information to
No,
know.
it's clear. This is good information to know.
So the whole point of this conversation
the discussion is to
kind of lay
out what would be a primary coder, primary care coder.
So these are things that they want to look for and be
aware of when you start coding or move down to code performance.
What are the things that they're
What are the things that they're going to
they are coding and billing for that primary care. Be aware that there's issues prioritization with Medicare Part or you need to be aware of the actual like anything that you know about them.
I apologize, John, but you cut out about halfway through your questions, and I don't hear the backside of it. Julia, y'all having that same problem?
Yes.
Okay, I'm sorry, John. Your signal's cutting out on us there, so
I'm not sure why it's doing that.
we're trying to guess. We're trying to guess what your questions are.
But back to some questions that we have. So,
So,
what are some tools
that you want to have
right next to you that
right next to you that way you go to them
in your
in your coding
or
or
ways to
happening with the
I'll let one of the professional coders here do it. I just have the letters after my name so people get CEUs. I'm not a professional coder.
What was the question?
What are three things that you use in your daily life as a coder for primary care? Like, what are things that you have right in front of you to code it?
I use Codify, which is what is it? A system.
It's basically a math system that basically encompasses regulatory and also the fee schedule local to you, alongside the modifiers. And if it would have any type of issue, which they call a medical unlikely edit, in terms of how many times you can build.
What else do I use?
Let me add into that right there. About 12 years ago, long before Codify came out, I came out with one called Coding Advisor. And in it includes NCDs or LCDs for every code, local coverage or national coding definitions. And it includes in there the NCCI edits, so that way you can find, as she pointed out, whether or not this is already being bundled or grouped into something else and not separately billable, whether it is separately billable. Then you need to have a breakdown of, as she said, also a breakdown of all the modifiers and which modifiers are accepted by commercial carriers and which ones by Medicare. Because there's a lot of confusion with offices out there using the wrong modifiers constantly or leaving the modifiers off. And then we have, at least my own program has a scrubbing program in it. So if you put in the codes and the diagnosis and the modifiers, it's going to automatically check and see whether or not meets all of the other guidelines, like she said, medically unnecessary edits or NCCI edits. And then you have to also match up on whether or not the ICD-10 is going to justify that particular service. I would say, and correct me if I'm wrong, ladies, but one of the biggest problems I find in primary care claims coding, or at least the claims itself, is that someone in the office is not matching which diagnosis goes to which procedure. And they'll list the first diagnosis for everything down there. And the first diagnosis might be diabetes. And then you look down on the line items and you find the first line item's an office visit. Cool, that'll go with the diabetes. And the second line item might be an EKG, and it's linked to, in block 24E, to the diabetes. And that ain't going to fly. The third one might be, I've got an ear removal and impaction 69209 or 69210. And again, if it has an A, not going to fly. That's why the coders have to make sure they are lining up each one. And oftentimes, you have to go back and ask the provider, why did you order this CMP? Why did you order that CBC? Which diagnosis were you, or which problem, not diagnosis, which problem, so that they can go ahead and link them. Am I correct, ladies?
Yeah,
100%.
And that's probably one of the biggest reasons I see denials is block 24E is not being matched up because someone that has no idea what coding is trying to do it. And by the act of having a wedding ring on their finger, the doc says, well, my wife's going to do the coding. Well, my husband's going to do the coding, and somehow that's supposed to impart all the knowledge of Frodo into your head from this magic ring. I know, I get off track. Forgive me.
That's why doctors should hire coders.
Amen. And if you look in Hezekiah in the Bible, it doesn't. Okay, there is no Hezekiah, but okay. Now I don't hear John at all.
I don't either. John, we can't hear you.
John, we can't hear you.
You're muted, man.
We can't hear you.
We can't hear you.
All right, can you hear me now?
Yes, sir.
All right,
So
let's talk
let's talk expectations.
So
If a
brand new
coder wants to get into primary care coding,
what kind of
skills do you bring
when they apply?
and
What do you
what you look for individually in candidates?
Usually what I look for is AR. It's not usually something that you like gloves, but denials shows you where to look for. The other thing is that we usually look for like back end in terms of understanding where the medical records, are kind of housed. I know AR is a big one for us.
And
I think understanding the whole process is good to know.
all right, so when you read a job posting, a lot of these roles have a mandatory requirement of experience. Is there anything that say a brand new coder that would help to your requirement? What can you look for? Is that something you'd like to have to follow? You have to have experience when you interview people.
Not necessarily. We usually end up kind of, especially with the clinics. We tend to basically keep it to where they it's not that it's for 2 years experience. It's kind of flexible in regards to that. If they're in the process of getting their CPC, or if they're in the process of actually trying to get that education, we will be more than happy to actually open up possibly our AR position, or even a little bit higher, to basically giving them that step in the door, and then actually allowing them to go further into surgery coding, podiatry, some of our routine billing, our facility side as well, if they really excel at it. So I mean, we kind of give them a wide variety of paths.
I would also say, instead of a 2 years experience, I have seen some people that were not certified coders that could code circles around me. Okay. I've seen some certified coders that may have passed a test, but they couldn't code. I mean, if they were, I mean, I don't know how they passed the test, honestly, because I got to tell you, that was a tough test. I was thankful that I got to pass it the first time I took it. But I think what's more important is the person's attitude, their adaptability, more so than the experience. We're constantly hiring new employees in my companies. I own a couple of companies, and the attitude and their the willingness to learn is something that just really stands out for me, more so than experience. I just say that as an employer. You're muted again, John.
Can't hear you.
You're muted, John.
Can't hear you.
That's all right.
Okay.
Kind of get rid of the V button. But when you handle the one primary care, one and nuclear, what are some of the things they prepare for in advance? Make sure that they have some kind of advantage in the interview situation. What do they have to bring to the table to kind of catch your attention?
We'd always like to be kind of like a team. Kind of like what Don said. They're willing to learn, because there's always a big learning curve, and the data is always being updated constantly.
Can't hear you.
John, you're muted again.
All right. So open up the audience. If you have any kind of ask them, opposed to our here, we can wrap us up a little bit.
Is that to me?
Oh, no,
I don't see any questions coming in. I don't know where we would see them, though.
Yeah. Let's see. No one has if anybody has any questions, feel free to ask. We can share them with the panelists and how they work. But in the meantime, you have advice anybody interested in primary care or interested or practice coding?
I didn't I didn't hear the question. I'm sorry.
Do you have any advice anybody in primary care coding that you touched on?
Yeah, I would say if you're interested in primary care coding, find somebody, get mentored as much as possible. When I got started in this company, or when I got started in this business, honestly, I'd been selling pegboard systems to doctors. And spending my own dime, I started attending seminars and taking notes like crazy, trying to read everything I could, attend whatever free webinars you have. And there's a lot of free information out there. that you can get a lot of good information off of. I've got probably 25 or 30 free webinars on my YouTube channel, and I know others around the country are doing the same exact thing. Terry Fletcher gives away a lot of stuff. Sean Weiss gives away a lot of them. Shannon DeConda gives out a lot of them. And even there's still some out there from folks who are no longer with us, like John Bishop. We lost John a while back, about a year ago, but he's still got free stuff out there. Watch everything you can, ask questions, join free different listservs. I've got about 1,000 people on a free listserv that people post a question, and it probably 90% just, oh, you're on it? Okay, Jennifer.
Yeah.
And people, most of them just lurk and they read and learn. And if somebody asks a question, and then you'll post out the answer. So all of that, and just learn as much as you can that way. You don't have to go out and invest. In fact, I do not recommend you go out and invest $15,000 because you saw an advertisement in a TV guide and to become a certified coder, and you can do it in 6 weeks and 2 hours a day or whatever. Don't go wasting your money like that. Find someone else and ask them questions. It's kind of like Zig Ziglar once said, and I was a fan of Zig Ziglar, Jim Rohn, Paul Harvey, all of those guys. Go find someone that's successful, take them to lunch, and ask questions, and they will be glad to guide you in the right direction. Don't do it at a hamburger. Go for a full 4-course meal that's going to take an hour, hour and a half, so you can get more questions and time with them. Find somebody successful and do that with them. Ladies, what would you add to that?
That's good
That's
advice.
good advice.
I started following basically John. I follow Terry as well. Sean. Christine. I pretty much have people on my LinkedIn in terms that I follow in this industry because of the fact that I love it so much.
It's a neat field to be in, and we're able to be a blessing to others, and that blesses us. Well,
I got a credit to LinkedIn user on here. So how can we start helping primary care providers? What resources you start using providers if we're missing? There's so much out there.
this is going to sound self-serving. I'm going to tell you right now. But I spend 90 minutes with primary care providers and their staff and their billing folks and ask questions and make suggestions. And at the end of the meeting, they don't pay me anything unless they believe I've helped them increase their clinic income by at least $50,000 a year. And I ask them that question. If you think I've helped you by $50,000, then you'll pay my $500 consulting fee. If you don't, you don't owe me a penny. And that's one way of doing it. And again, I know it sounds self-serving, but ladies, what other avenues or routes would you recommend they take?
So usually the way that we've done it is that we actually bought a consulting company from upper management, and they're the ones that suggested the RPM. It's going on for about two or three years now, and so it makes it different with reimbursement. It's dependent upon what exactly are in primary care. You can ask another coder that you're doing. You can actually ask them in regards to how you in overall for that clinic because that's not a HIPAA violation. What else?
I'd say Matthew 7:7 pretty well sums it up. I don't care if you're looking at the NIV, KJV, NEV, any of them out there, the New English Standard or whatever. But Matthew 7:7, ask, and the door shall be open. Ask, and thou shalt find out the answer. So just ask everybody.
All right.
All right. So we have another user, Jade Flowers. She asked for Dawn. What is the list of get responses? I think she meant your list of.
It's called Med Managers, and if you go to donself.com and scroll down, you can click on it and join it. It's got about 1,000. I think we went over 1,000 people on it right now, and some people jumped on there and they say, "Wow, that's a lot of emails," and then they jump off. But it's free to everybody. I paid for it. It's my way of giving back to the community.
A lot of info on there.
Pardon me?
There's a lot of info on there.
Some good conversation.
Yes.
Sometimes folks will disagree, but
Yes.
they do so respectfully. That's the only rule I've got.
Yes. Yeah.
But it's everything from collections to billing to coding to workers' comp to ERISA. I mean, you could do a whole session on ERISA sometime, but not tonight because I got to go in there and make supper, but some other time.
All right.
Well, we only think of 1 hour, so I think our episode one guest. So we're gonna go over Mr. Don Self and Don Associates. I spell associates wrong. But his website is www.donself.com. Which I was actually trying to tell myself today. How do I introduce you? Do you go by the self? Do you go by Dawn? You just answer yourself. How do you refer to your
Just Don.
self?
Everybody just calls me Don. I don't care who. Just Don. Keep it easy.
And we have Julie Miller.
who is the
integrity analyst.
American Medical Center. If somebody wants to connect with you, how can they get a hold of you?
What was that?
If
anybody wants to connect with you, ask questions in regards to primary care, you already do. How can they get a hold of you?
LinkedIn would be best. I do have a very active LinkedIn account. I have a lot of people on my but I will have time to answer questions. If you have in terms of like questions for advancing the field, I'm getting.
All right. Last we have Jennifer Kropp, who is with Capital Health. She's a primary care coordinator. Anywhere anybody wants to get a hold of you to ask questions.
I don't have anything
No.
that they could ask questions. I do want to say if anyone's thinking about becoming a coder, join group social media group. People bounce things off of each other. Don's site. Information passed through various social sites. It's constantly being new guidelines come out, codes come out. It's just really good to join as many things you can and get the information, ask questions, find like people and ask away.
All right. Well, thank you all for today. We're gonna wrap it up. If you haven't, reach out to me. My name is John Biscott. I am with commercial coding service, www.codingservices.com. Still website construction. On there. I will put links to Mr. Don's website on there later this weekend, as well as other of our guests of previous episodes. And next we'll be talking about coders, and we have 3 fabulous panels already set up. So this is Monday, the 18th, 7 Eastern Standard Time. We'll join you then.
Thank you, folks. Thank you, ladies. I enjoyed being up here with y'all tonight.
Thank you.
Bye-bye.
Thanks, John.